Welcome to ASRM Today, a podcast that takes a deeper dive into the current topics in reproductive medicine.
I'm Jeffrey Hayes. On the show today, we are hosting a discussion on male infertility and men's health. Joining us today is Akanksha Mehta, Associate Professor, Residency Program Director in the Department of Urology, the Emory University School of Medicine, and Michael Eisenberg, Director of Male Reproductive Medicine and Surgery, Men's Health, and Associate Professor in the Department of Urology at the Stanford University School of Medicine. Thank you both for being here today. Dr. Mehta, I will now turn things over to you.
Thank you so much, Jeffrey. I'm really excited to be talking to Mike Eisenberg today. We will be discussing the intersection between male infertility and somatic health. And this is definitely a topic where Dr. Eisenberg is a subject matter expert. So Mike, let's start off discussing the association between male infertility and chronic medical conditions. Much has been published about how medical conditions like obesity, diabetes, sleep apnea have an impact on male infertility. What are your thoughts about male factor infertility being a predictor for the development of these conditions in a patient who's otherwise healthy?
Thank you, Akanksha. It's certainly great to be here and really great that we're talking about this. I think men's health is certainly an important focus. And reproduction, I think, is very much linked to, men's overall health. So I think it's sort of a key point here. Now, anytime we talk about sort of this link between fertility and how it looks to the future and how it may tell us about, other diseases the man may be at risk for or his health trajectory, I always like to take a step back and just think about how health and fertility are very much linked in the current moment as well. Because really, a healthy young man is also sometimes dictates how fertile he is. There's a lot of examples of that. And I also always kind of think about why this two may be linked. And there's sort of several hypotheses that have been put forward about why this link may exist. And so usually the first one that's proposed is a genetic explanation. So we know that probably about 10% of the male genome is devoted to reproduction. And given the fact that there's only about 25,000 genes in the body, it makes sense that, some genes that operate in reproduction may also operate in other organ systems as well. And so you can imagine if that gene is not working well in the reproductive system, there may be other health consequences as well. So again, there may be some genetic links. The other proposed etiology is hormonal. So infertile men, on average, have lower testosterone levels than fertile men. And testosterone has also been linked to health trajectory as well. We know that men that have lower testosterone levels, seem to have a higher risk of, chronic diseases, even mortality in some studies as well. So that may also provide the link. There also may be sort of developmental or in utero factors as well, the developmental origin of disease or the Barker hypothesis. And so a corollary of this suggests that, different sort of factors or insults can lead to testicular dysgenesis, which can impair sperm production, may also lead to higher risk of, other, genital disorders. And other studies have shown that, these developmental insults may lead to chronic diseases in men, heart disease, diabetes, et cetera. So there may be a unifying theory there. And then another really kind of key component here is this health factors. So there are conditions that affect health, but also affect fertility that we know directly, like obesity, which you mentioned. So we know that, obese men have higher risk of mortality, diabetes, heart disease, et cetera. But obese men also have higher risk of having lower sperm counts, for example. And there was a really elegant study done a number of years ago that just looked at a group of infertile men and compared them to a group of fertile men and found that infertile men on general had higher risk of chronic medical diseases just at baseline. And so that really suggests that, there may be some underlying diseases. Now, I think as you pointed out, these are reproductive age men, in their 20s, 30s, and 40s. And in general, they're very healthy, or at least they think they're very healthy. And so, if there are some markers maybe that we can see earlier about, prediction of later health events, then I think that may be really an opportunity to try and understand. So there have been some studies to look at some of this sort of longitudinal follow-up on these infertile men to see what risks, they may be, what sort of diseases they may be at higher risk for. And, like you pointed out, I think there's certainly evidence that there could be some metabolic diseases like diabetes, higher risk of heart disease, a higher risk of peripheral vascular disease have been studied. And even there have been studies to show that, men with lower sperm counts may be at higher risk for death as well, kind of the ultimate outcome. And I think, kind of getting on this sort of topic of cancer as well, another very, important chronic disease. There have been studies that show that infertile men may be at higher risk of cancers too. Male cancers like testicular cancer, prostate cancer has been studied, but other cancers as well. I mean, sort of the broad look at all cancers, for example, and then specific cancers like lymphoma. There have been a handful of studies to demonstrate that as well. So I think it's sort of an important aspect to think about. And hopefully, as we kind of continue to talk, we can sort of think about, the implications of patients in our clinic as well.
Yeah, I think that's really, valuable insight. And I do want to get into the details of what you just mentioned. I wanted to ask you before we move on too far off the broad topic, whether you think environmental factors play a role here as well and what their contribution is, because I feel like environmental toxins and exposure to environmental factors are becoming increasingly a bigger problem for our patients, whether they recognize it or not.
I think that's really key. And I think it sort of depends what bucket you put that in, whether it's sort of lifestyle, current health, current exposures, how you, sort of have lived, or, you could also put that into the developmental bucket as well. Right. And I think that, when men, I'm sure just like they ask me, why is my sperm count low, or why do I not have a sperm count? And a lot of times we can't really answer, but one of the possibilities, certainly it could be an in utero exposure. And what that is, again, it's going to be very difficult the current time to be able to identify it. But it may be that some, gestational exposure led to, disorder of genital development, which led to these lower sperm counts or absent sperm counts. But it also may be, during puberty or, kind of during some point in life, some of these exposures may have arisen and may lead to, these infertile phenotypes. Certainly there have been documented cases of certain pesticides from certain professions causing impaired fertility. So I think there's certainly adequate examples of that. And I think it's, sort of on us as investigators to try and understand and synthesize to the extent possible of things that, men and couples should try and avoid.
Yeah, absolutely. And you hit an important point as to what you say to the patient when they ask you, why is my sperm count low? Why do I have X, Y, or Z numbers on this particular analysis? So when you are seeing a patient for the first time in the clinic, for example, how are you counseling them about their overall health and the impact that may have on their reproductive potential? What are some of the pearls you are sharing with your patients?
Yeah, I think, a lot of this, I don't want to be alarmist about any of this. And I certainly don't want to, tell a patient that because his sperm count is X, his risk of having this condition is elevated a certain amount. Because I think we really don't understand this association, how we can, necessarily change the trajectory or why this association exists. But I just try and give good health advice, broadly. So, we talk about, good diet, exercise. I think those are certainly very key points. I think most people probably understand that. And it may be that hopefully for some individuals, reproduction can kind of be the carrot that'll push them over the edge to try and make these, important, lifestyle changes, rather than eating fast food, maybe eating something a little bit more nutritious, may make a difference, or, to get into an exercise routine, for example. So I think all those are important, for patients that, drink to excess, smoke. We talk about those as risk factors as well. And then for patients that really aren't connected to the health system, for example, I'm the first doctor that they've seen since, they saw their pediatrician a decade ago, or maybe the first doctor they've seen ever. I try and get them plugged in with a primary care doctor to check other things that we know are important, blood pressure monitoring, cholesterol, fasting glucose, all those things, that are very important, in terms of chronic disease identification or prevention. So those are sort of the general health guidelines that I try and give men. I try not to scare them about any of this, but we certainly do talk about overall health and how that may improve their current status.
Yeah, absolutely. And I think you make a really important point there that, men in general do not seek out medical care, preventative health, or otherwise with the same frequency that women do. So for many men coming in for a fertility evaluation, that is their first interaction with the healthcare professional in a long time. And it's a unique kind of window of opportunity for us as physicians to talk to them about all of the other health screenings, preventive health measures, health education that they may have missed out on, that their female partners have been getting all along because they have been more connected to the healthcare system. You mentioned that you will often try to get them connected with a primary care physician and talk to them about general overall health. I certainly do the same. What are some kind of system-based ways that we can enhance that, perhaps at the institutional level, or even broader, public health measures? Where do you see this being going in the future?
That's an interesting question. I think kind of thinking about how we can sort of turn this link between fertility and health into something actionable, I think is important. I think it starts with education. I think just sort of to alert everybody. I think, sort of different incentives will drive different people. So, I think for couples thinking about, reproduction or starting a family, I think it's important information and certainly can make that journey a little bit easier. And I think there's also evidence now that, the health of the father also impacts the pregnancy trajectory as well, the health of the child, having a lower risk of preterm birth, for example, a higher risk of just a healthy infant, the healthier the father is. So I think those also may be hopeful incentives that we can use as well and just, teach from an education standpoint. I think trying to partner with, our primary care colleagues as well, just trying to remove friction from some of these things. I think that we're all live busy lives. Obviously, I think the pandemic has certainly, made some things harder, some things easier. But just trying to figure out, why patients maybe don't want to go to the doctor, what's prevented them, whether it's location, difficulty with scheduling an appointment, et cetera. And then, to the extent possible, maybe having our, clinics being able to facilitate that, at the front desk. At our institution, we're able to, schedule patients into primary care clinics. So that makes it just, again, a little bit easier, sort of one-stop shopping. Also sort of geography is important too, where patients live, where the primary care offices are located. Just like you and I, we have maybe one or two clinics around town, but primary care clinics are strategically located all over. So kind of understanding what neighborhood patients live in, what the best site of access may be, is another, potential opportunity as well.
Yeah, I think a challenge for all of us to think about, barriers in terms of access for our patients' geography, as you mentioned, or time constraints. Just ease of scheduling is a huge barrier, not having to make that second or third phone call. So I think all of those are really key ideas. One of the things that was noticeable to me when the new AUA ASRM joint guidelines came out or the updated version came out in October of last year, was that there was this tremendous emphasis on early evaluation of the male partner, but also, as you mentioned, the contribution of that paternal genome and paternal health, paternal age to development of the embryo and health of the future offspring. Where do your or how do you counsel patients about advanced paternal age, for example, or health conditions that they have and that impact on their offspring? Because I'm sure your patients are asking you these questions as well.
Yeah. I think when we think about reproduction, I think, you and I certainly probably think different than most people, but generally, most probably think about the woman. And I guess, it certainly makes sense. Obviously, pregnancy has a tremendous impact, and probably, I certainly don't want to discount it, but probably the larger impact compared to the man. But, the man contributes half the genome. So it certainly makes sense that there are going to be some powerful influence as well. And I think, over the last, few years, we've started to see more and more data come out about the importance of that. And I think as we're sort of accumulating this information, starting to use it to engage couples and engage men a little bit more. So, as you pointed out, the new guidelines came out, the AUA ASRM guidelines, and did look at some of these risk factors and ways to counsel. So, I think in terms of paternal age, it's a discussion that I certainly have. I think it's always a question of what you consider an older father, right? The oldest father ever, I think, was like 95 or 96. So I haven't had any patients nearing that to set a new record. But, the biologic potential certainly persists. certainly persists for a while. So, I think it's probably sort of a continuum, a spectrum of risk. And I think we certainly discuss this. Now, most of these risks, I think, are fairly rare. We talk about like these rare conditions like achondroplasia, for example, or other neuroskeletal disorders. The risk goes up slightly. So I think I try and sort of couch this in this discussion of absolute risk versus relative risk. So as men get older, the relative risk of these conditions definitely increases. But these are very rare conditions, right? And so the absolute risk doesn't really change. So I think the analogy I usually use is like the lottery. Like if you buy 2 lottery tickets, your chance of winning doubles, but it's still probably not going to happen. So obviously these events are not anywhere close to as rare as winning the lottery. But I think it helps people sort of understand risk a little bit. And in general, I think most men don't want to trade biological relatedness for these sort of low probability events, or this risk of low probability events. But it's certainly something that we discuss. And we also talk about health. And I think that's something that's actionable. Obviously, paternal age is not necessarily actionable, especially when we see these patients trying to have a baby. I mean, I think that discussion hopefully could start, just like, we take kids for these sexual education classes, in, very early, late elementary school or middle school, that sort of time frame. I think it maybe potentially you could start to talk about some of these reproductive aspects as well, from the male side. And just, I think men are used to maybe thinking about their timeline as unlimited. And I think in some ways it could be perceived like that, but again, there may be risks that go up in the short term. So to think about, reproduction maybe a little bit earlier as well. So I think I think talking about age is a little bit challenging again, because there's not a lot patients can necessarily do about that. But I think health is certainly very actionable. And I think having patients sort of understand that, looking at the timeline for sperm production and, real things that they can do, whether it's initiate an exercise program, change their diet, and hopefully, make positive impacts in that regard.
Yeah, absolutely. And I agree with you 100% that, when we're talking about health of the offspring or health of the embryo, we are almost always first thinking of maternal factors and then thinking of paternal factors. I was excited that the CDC started collecting data on paternal factors. So as you know, the CDC has had this data collection program called PRAMS going for a long time, where they collect all sorts of information about maternal risk factors, and they started collecting paternal factors in about, I think, 2019. So hopefully in the next few years, we'll start to see more publications come out about all of the paternal behaviors and paternal habits and how that modifies reproductive outcomes. And I'm hoping that will help, educate physicians, patients, the general community about the importance of paternal contribution to health of the offspring. What are you telling your patients when they ask you whether genetic testing is indicated for figuring out whether paternal risk factors are going to affect their children? That's a common question that I will get from my patients, whether there is additional testing that they should undergo to make sure that there are no additional risks to their future baby.
Yeah. Actually, so I just wanted to hop onto that your CDC point for a brief second. So I want to congratulate the CDC on that. I mean, I think in the last, probably 20 years or so, they've really kind of updated thinking about male reproduction, like the National Survey of Family Growth, which looks at fertility, parenthood, contraception in the United States. Used to be a female-only survey, and then in 2002 they also had a male component as well, and they've continued that on. And then, as all the IVF cycles in the United States are captured and reported to the CDC. And just recently, they started looking at male variables. Before there was really nothing collected. Now they've started doing age and a little bit more about semen quality, health conditions of the male partner. So I think that's all great. To the advance and just sort of understanding of reproduction in general. And it's really a credit to the CDC that they've started to collect that. Now, back to the question about, genetic testing. So I think it's, challenging. There's not a lot that we necessarily test for, during IVF cycles, from a male component. Now, certainly if, either of the parents have a known genetic condition, that can be tested for to prevent transmission. And there are certainly some conditions that we test for, in the fathers, somewhat routinely, like for men with very low sperm counts, we can look for, We do a karyotype to look for aneuploidy. We can look at the Y chromosome to see if there's any microdeletions present. In some cases, we'll do cystic fibrosis screening as well. So those are conditions that can be, that we can check for. But otherwise, sort of routine genetic testing that we do for an embryo would largely be related to aneuploidy. And most of the aneuploidy is probably maternal in origin, although I think there's maybe 10% or somewhere around that is paternal. So I think, certainly it's not unreasonable to think about that. But I think, for some of these rare conditions like that we talked about, these rare paternal age-related conditions, there's not genetic testing that's really done for that.
Well, thanks so much, Mike. I really enjoyed, getting into the details of some of those questions today. Any parting thoughts for our listeners?
Yeah, I think sort of the key points I would say is that, when we think about the man and probably, and I think the woman as well, reproduction and health are really very much intertwined. I think there is certainly associations between fertility and later health, but I think, it's a reciprocal relationship. So when you think about health, it also impacts fertility. And there's a lot of different conditions that we can think about that affect that. And I think I would say, depending on who's watching this or listening to this podcast, talk to your provider, talk to your patients about this association.
Absolutely. I second that 100%. And looking forward to reading more about this in the literature in the coming months and years. Thank you so much for talking to me today.
My pleasure. Thank you.
This concludes this episode of ASRM Today. For show notes, author information, and discussions, go to asrmtoday.org. This material is copyrighted by the American Society for Reproductive Medicine and may not be reproduced or used without express consent from ASRM. ASRM Today series podcasts are supported in part by the ASRM Corporate Member Council.
The information and opinions expressed in this podcast do not necessarily reflect those of ASRM and its affiliates. These are provided as a source of general information and are not a substitute for consultation with a physician.